If it's okay, John, I'll let you introduce yourself because you've got quite a strong background, not just in podiatry, but also in biomechanical. And so really grateful that you could be here today. And I'm really looking forward to your presentation.
Well, thank you all for coming on this chilly day. It's not raining, so it's the better of the days to come out. So I do podiatry and clinical biomechanics. So some of my work is looking at this sort of thing, this ingrown toenail. Basic foot care, that's part of my work. And I started doing that in about 1987 when I graduated. And then I re-qualified in clinical biomechanics. So that's looking at gait or movement is my specialty area. So when it comes to anything from infants not walking correctly, people post-stroke, people with injuries, running injuries, anything like that, that's my specialty area. So many years of post-grad study and trying to learn how humans move and how that interacts with injuries and muscles. So part of today, what I want to do is show you some ideas and things that you might be presented with. A person saying, I've got this, what am I going to do? They may be walking with you and they're showing that they have pain, and so you can start to have a little bit more of an idea about some of these things and how you can direct them a little bit. And of course, this doesn't then make you, you're not going to take on board with this and say, right, these are the things you have to do, right? You have to clean it and do this. But at least you can sort of look at relative risk and give a bit of an idea and help people that little bit more if they're having pain or something that's noticeably not quite right. So the first stuff I'm going to go through is stuff that you can see, and this is at the lower end of the risk level, okay? But there are still risks. So this one here, ingrown toenail. So this is a nasty swelling area up and through here. So that's a piece of nail that's got stuck in the skin, and they've cut it in correctly or it's broken off, and it's piercing the skin and it's creating a wound. And you can see all of that sloughy red skin. If that's left, it causes pain. So a person might be in quite a bit of pain with this for sure. But there's another risk with this, it's a wound. And what happens when we have wounds? They can get infected. And always think about infections. If something's red, you know our cardinal signs of infection? Heat, red, discharge, and those kinds of ideas. And you can actually see that. What's a bigger risk of infection? Sepsis, exactly. And once we get sepsis, we start to see a red line. So if you see this, yes, you would say that's probably colonised with a bacteria. It's going to be infected, but at a low level. Once you start seeing a line, red line tracking out of that, if someone shows you something and there's a red line walking its way out of that wound up the foot, they're in some trouble. So do be very, very strongly advising them to get to see a GP for antibiotics and assessment. So clinically, we would deal with that by removing the piece of nail. A GP may need to give antibiotics for that. So this person may be in quite a bit of pain, but they may be still ignoring it. One of the risks, of course, particularly in your clients, the real risk group for infection is people with artificial limbs. So if you've got an artificial limb like a knee or a hip, or a heart valve, even worse, infection will track to that. So often when people get an infection in a toe or a finger or in the eye or something, the infection can track to that artificial joint and it will destroy it. So it can cause quite a bit of damage, and particularly if it's an artificial valve in a heart, that can be devastating. So even though this can be something that can be almost ignored, anything where there's a wound with risk of infection, they need to get it looked at. And this can also stop them wanting to walk. They might say, I'm not walking today, my toe's too sore. So this can be a real problem. So certainly they do need to see someone clinically for this. Advice you could say to them is, yes, this is a potential risk for infection. Keep it clean. Wash it, keep it clean with maybe salty bathing. Antiseptic on it is a very good idea. And putting a clean dressing over it. The amount of people I see that come in with toilet paper wrapped around it. Something nice and absorbent like toilet paper, and of course it just gets nasty and gluggy. So just give them some advice, keep it clean, get some antiseptic on it, stop it getting infected and get someone to look at it. They do not settle themselves. This here's a corn, so this lump here. This is the lower end of the risk level. These infrequently cause any serious harm, but they are very, very painful. And again, this can stop a person walking, absolutely. It's just hard skin. So this person here has got a high focal area of pressure on their skin, and as they're walking and moving, the callus is building up and it becomes a big lump. And some of them can go 2 or 3, 4 millimetres into the skin. So if you can imagine putting a small stone that deep in your shoe and walking around on it, It's pretty much what it feels like. These don't frequently cause any huge risk. They can ulcerate, but they become a contained ulcer. But in, quite vulnerable people, you don't want that kind of tissue damage. You want to get them sorted out. These can be certainly cut away to get rid of the pain, and then often shoes are a big thing. Their shoes may be too hard. I've got lots of people who still come in their hard leather shoes that they've had since the 60s, when they could be in a nice cushioned trainer. Walking in a trainer with this, we're nice and cushioned inside, it makes a big difference. So that's something that you can actually help out with and maybe direct. They may need some clinical care, but also some softer shoes. This is another corn, quite a big one here, and that would be quite painful again. So pretty simple lesion, pretty painful, and it will certainly make people limp and prevent them wanting to go out.
What causes corn?
Just pressure. So, for example, if we look at this foot here, you can see how there's a bit here, nothing, and then that. So that's a high pressure area. And it could be a high pressure area for a lot of reasons. This joint, which is in the forefoot, if you can imagine this being my foot, this joint here is dropped lower than the rest. So it's actually slightly plantar flexed, we would call it. And so it's higher pressure. So when they're walking, there's more pressure focusing in a very small area. And that's always what they are. They are a high pressure area. And there's lots of reasons for that high pressure. Sometimes we'll see it in collapsed shoes, that the shoe is collapsed and they're rolling onto the outside of their foot. And so then they would have one right over on the other side. And in fact, if we've traced that idea forward, if we go to this one actually, I'm going to go forward one. These are clawed toes, okay? You can see these toes here bunched up. So this is another place where a person could get a corn because that's now a high pressure area. So this here, bumped up toes. What do you need for that? Well, you need to have shoes that aren't too low. So this person really would need to be in a trainer type of shoe. There's not too many leather shoes that would accommodate that. It would be sticking up, pressing on the leather, and that would be pretty painful. But I can actually see there's no corns on the top, but there certainly would be a lot of the time. That person's clearly wearing shoes that are not particularly tight on the top. And that's the thing, trainers are really the best option as we get older. They are the best option. They give better support, they give nice room and elastic material over the top, so they can make a lot of maladies go away simply by having that. So this is a type of digital deformity. This is created most likely just by genetics, just genetic predisposition.
Before you go on,
Sorry?
Could you go back to the first slide?
It's the first one?
I just wondered how frequent it is that a toe is in from the big toe and bigger than the big toe.
Very frequently. So it's probably more likely the second toe will be longer than the first. And quite frequently, the third and the second longer than the first. So they're actually having the big toe the longest is one of the least common. And in fact, this, having all of the toes relatively the same length and the second longer, is actually a slightly more robust foot. When we have this kind of very long big toe and a big angle all the way back to the lesser toes, is a little bit less robust as a foot. What we call the Egyptian foot. The Egyptians tended to have that. And every single person I tell them they've got the Egyptian style foot, they get the superior look on their face that is incredibly hard to wipe off. But I see my duty is to wipe it off their face by telling them the Greek foot, which is squarer, is more utilitarian and a little bit more robust. Anyway, it doesn't wipe that off their face. So they do like the Egyptian foot. Now this here is chilblains. So chilblains, we're seeing a lot of them now at the moment. Chilling is like a very minor gangrene or frostbite, basically. And it's where the circulation of the skin is trying to hold all of that circulation in the very surface of the skin deeper around the heart. But then when the circulation of the skin produces metabolites, because you're moving and doing things, it just poisons the skin. So you end up with this kind of tissue stress. This would be tissue stress. But we're looking at this one here, so that one there is a little bit more than tissue stress. So this is a general sign of chilblains, which will be the skin will be ruddy, red looking, and you'll see it at this time of the year. Tips of the toes getting a little bit sort of irritable looking, a bit itchy. But this person here, I would say, is at quite high risk. because that toe is a little bit more than just a bit chilled. I would say there's quite a significant vascular event potentially going on there. How to stop this? The main thing is it would have stopped about 6 weeks before this happened. It's thinking ahead. Winter's coming up. Stop wearing sandals. Woolen socks. Keep your feet warm. As soon as the feet get very cold, this event can happen. And once it happens, you've got this event will continue for this person for several weeks, if not months. So it takes a long time to settle once the event has occurred. So it's warm socks, woolen socks, not trying to use sandals through the winter. It's keep your feet warm. This is about prevention. Once it's happened, it takes a long time to settle down. The risks can be because here we can have a much more profound vascular loss, and that toe could become gangrenous and need to be removed. And that's a place I worked in London called Guy's Hospital, where we dealt exclusively with high-risk diabetics. I remember the first time I saw my first patient, and I slid my chair backwards so I could see the podiatrist in the next cubicle, and I said, "Julie, I think I've got gangrene." And she slid her chair back. I thought she was going to say, "Oh my God," and she didn't. She says, "Yes, and you'll be seeing 20 more of these today." That's all we saw was gangrene. Gangrene, gangrene, gangrene. Toes coming off, toes dropping off. And so, but to make the point, that is the highest risk people we were seeing. So most diabetics, luckily, that I would see today are going to do very well. They're not losing toes frequently. So the main point to make is you don't want anything going that colour. The risks start increasing. So chilblains, irritating and painful for most people, but it can go a little bit further than it should. So keep a bit of an eye out, making sure if it's a cold day you're going out, are you wearing warm socks? Now the other point, I shouldn't have said that because there's no such thing as a warm sock. I've said that 1,000 times. A sock has no temperature. A temperature of your foot will warm the sock. So what I always say to people if they are at risk of chilblains is warm their feet before they put it in the sock. And that does not mean stick it inside in front of a heater. It's warm it up by the hand or anything like that to get the skin warmed up, and then put it in the sock, and that temperature hopefully will remain there.
Heating up wheat sacks and putting your feet on wheat sack is a really nice, easy way of heating your feet.
It is, and as long as it's not too hot. And the whole thing, so technically when it comes to chilblains, it's the cooling and the heating. It's not the one event, it's the cooling. If the heating happened very slowly, potentially it wouldn't occur. So we saw a lot of this in England where they have lots of 1-bar heaters still, and they would get cold feet and they just put their feet right up against the heaters. And then the thermal stress on the skin would heat too quickly, and then the chilblains would occur. So it's making sure if they're going to use a wheat pack to get their feet warmed up is not too hot, a nice comfortable temperature.
Are people that use sort of like the traditional hot water bottle, is that a problem?
Not really, as long as it's not too hot. And you see, the point is this type of vascular event, I can see the skin has vascular issues anyway. And often these people will not know what's hot. They will probably put their foot onto something that's way too hot and they won't feel it because their sensory system is very, very low. If you cool your feet a lot and put your feet onto something quite hot, you won't feel it. So I say to them, put your elbow on it. Test it here. This is not going to cool down. Test it with your arm first. And the amount of times people say, that was good advice because I put my arm on it. It's like, oh, that was way too hot. So it should be a nice, comfortable, almost a little bit more than body temperature. You're not trying to heat it rapidly. So this can go very, very pear-shaped in a candidate who has vascular peripheral disease, that sort of thing. And diabetics as well. There's our clawed toes again. Bunions. So bunion, of course, is this angle of the big toe. So very, very common problem. It's just the joint has become unstable and then the big toe scoots that way. Now, the big toe itself is not actually the cause of it. The cause is this big toe joint. If you can imagine this being my foot, this is the big toe joint. The big toe joint scooting that way. So the foot is flattening and widening through the forefoot. This will create a pressure area here. So if they're in a shoe that's too narrow, if you look at their shoes and you can see that their foot's stressing that shoe, give them some advice to get something a bit wider because that will potentially cause a lot of pain and potentially a corn because it's another high pressure area, or blistering and ulcers and things like that. You can see the other thing that it gets paired up with is our claw toe again, and you can see that toe's certainly not coming back into place, is it? Because it's propped up with that first toe. So can cause a lot of pain, A foot like this needs to have the right shoe, plenty of width. It also needs support. You know, the arch is going to have slumped as well. So they need supportive shoes. So look at what they're wearing. If they're just wearing a pair of hard leather lace-up shoes and you can see that the foot's this wide and suddenly they've squeezed it into something that narrow, give them some advice about a more comfortable shoe.
So would it take a while to get something like that?
To get it? Not necessarily. We'll sometimes see people progress within sort of 4 or 5 years to this bad, yeah. And we will see this also in teenagers. So some people are born almost with it. Sometimes you'll see, I would always say to people, if you don't have it by 14, you probably won't start getting it until you're sort of maybe 60s, that sort of age. So young girls particularly can actually almost be born with it. Well, not born with it, but they develop it very early, which is very sad. As a sort of
Do you teach like threading your fingers between your toes when your toes are warm after a shower or something to prevent it and
oh, bunions?
Yeah, and any of the support things to straighten it?
Not so much the straighteners. So a straightener, if we put a straightener in between there, it's just going to push that second toe higher. So if you're trying to push a toe that's anatomically out of position, if you put a spacer in, it's just going to push that second toe up and out. So it would actually just push this. So not very much spacers, but certainly strengthening. I always give people strengthening exercises, getting their toes moving, because stronger muscles will make it more stable and more comfortable technically. So I would always talk about strengthening, more than I would by putting spacers in. There's been a lot of the people now using those flamingo toes, I think, which it's like a rubber thing which goes in between all of their toes, and then they realise they can't put their foot in their shoe anymore because suddenly everything's got, you know. So I wouldn't recommend the spacers. Sometimes if this toe isn't too high, you can get away with a spacer, but it doesn't really anatomically stop anything happening. But it can make it feel a bit more comfortable. So there are some benefits, but main thing is getting them moving their toes. You know, getting those toes animated.
Excuse me. Can you have an operation?
Oh, absolutely, yeah. So surgery, when do we recommend surgery? In general terms, if it's painful. If people are saying, I can't walk or the pain is very high, surgery is an option that can certainly be used. But I've got dozens and dozens of people as patients who have bunions about that severe, they have no pain with it. So just because it's there doesn't mean it's a problem. If the shoe's correct, if they have enough support, keeps the pressure off it. And no one should have surgery on them unless they are having pain. So to have them done cosmetically, you could end up with some pain or problems later on. So I wouldn't roll the dice unless it was painful. But certainly surgery for the very painful disabled foot with a bunion certainly is a good option. So this is foot pronation. So you can actually see how the back of the leg and the heels are sort of angled out. So this is pronation. It's a postural issue of the foot. It just means they're collapsing. And this often is strength. And as people get older, the strength that holds all of our postural muscles in the right place tend to collapse in a wee bit. So this is just a postural issue. Some people are born with it. It's part of their normal posture. But if you've got people who are having aches and pains with their feet, where you see their shoes are collapsing out, you know, they may need a stronger shoe or some support and strengthening as well. So if you see this and you can see the person's having trouble with it, you know, they can do some strengthening exercises and a more supportive shoe can really help them out so they can get out there and walk with comfort.
So would you recommend they go to a podiatrist or to a physio?
You could go to a podiatrist, you could go to physio, osteopath. As many clinicians can help with this. They often, in cases, you know, they might just want to try an arch support from the pharmacy first. Just get something in there, or a more supportive sports shoe. So if this person was in something like just a normal flat type of shoe, this could be quite a problem. But then if they went into a more supportive sports shoe, potentially that would be enough support to stop it. So I'd always say, you know, start with the basics. Maybe a more supportive shoe, that sort of thing, and then potentially physio, podiatry, osteopath to get a little bit of maybe some strengthening program and maybe a bit of support. So it can cause quite a lot of problems, aches and pains, but pretty common. This is the opposite. This is the feet rolling out. So here's the heel, here's the arch. You can see how the feet are sort of rolling outwards. This is what we call a caver's foot. These people will tend to have more issues. because it makes their ankles unstable outwardly. So their foot's always on that cusp of spraining. They tend to have quite big calluses develop on the big toe or the outside of the foot. And technically this sort of foot is pretty rigid. You know, you try to move the foot, it's almost like concrete. So often as these people get older through their age, this foot will get into almost like a concrete rigid position. And it doesn't absorb shock well. So it's not the most fun foot to have. I'd prefer to have a pronated foot more than this foot here. But these feet may end up the person describing that they feel unstable. When they're on slightly unstable ground or pebbles, they might sort of feel that they're tipping. And again, a good secure shoe is very important for these people. They've got to have that shoe that gives them that structure on the outside. And you will see them, they will tend to sort of almost bow at the knees and sort of almost tip out. But they may not want to walk or may be limited with walking for that reason. So these do tend to be quite unstable. I've got quite a few patients I've seen probably in the last 3 or 4 years where I've had to make wedges to go in their shoes to try and just nudge them back in a wee bit. And that's made them feel so much better. You know, they just feel, oh my goodness, I feel secure now. So something to consider. Now if we look at knee and pelvis position, so we've got pelvis here, femur, knees, down into the feet. So we've got our 2 different knee types that you'll be able to quite easily see, is the bow legs, you know, and you'll just see this sort of thing, you know, the knees buckling out that way. This can be because of arthritis on the inside of the knee. If we get a medial column collapse of the knee, and that can end up with the knees increasingly going out. In fact, I had a patient many years ago who started out about where my legs are, and within about 5 years he's out about here because the whole inside of his knee had collapsed. And then surgery on that was just wonderful for him because he became so unstable. We then have this one, which is more common, and this will tend to happen as we get older, the knees coming together. Now some people anatomically are born like that, but often it's because of strength. So I can mimic that much more easily than bow legs, simply by relaxing my hips and just letting my knees collapse in. So now this is a position of weakness. As I collapse in, my muscles aren't supporting me, so my knees come together and also my feet will pronate. Now the other point to make though, this is more stable. So you will see a lot of people that have a lot of issues with balance, they will walk like this because this will feel actually more stable. When they're here, they've got much more precariousness. So sometimes falling into this position can, for some people, feel more balanced. So it might be because of balance they're doing that. It might be anatomical. But if you think it's severe, you might want to make comment of it and they may want to get a little bit of help with it. But often when we see this sort of thing, I'm thinking about buttock strengthening. I want to see them getting some sit stands to really power up those hip muscles, get some stability back into the hips again. So that's what you can anatomically see when the person's standing. You know, are they straight up and down, which would be ideal? Are they collapsing into the knees, or are they bow-legged? Again, if I was going to have one of these, well, I'd prefer to have that, of course. I would prefer to have this than this. It's a bit safer. This one here does tend to wear out the inside of the knees. So we do tend to see a lot of medial column arthritis with that bow-legged position, and it becomes progressive. So any questions there?
I have a question. The toe slip up the tall toe, how much could be attributed to the very pointy shoe?
Very little, very little. It's been one of the things that high heel shoes and pointed shoes, of course, for many decades have been the scourge of women's feet, causing bunions and calluses and all the rest of it. And an ill-fitting shoe, and a shoe that is too tight and too pointed, of course is not good for the foot. But men will have this as well. So we see a similar level of men with bunions. We have a similar amount of men with clawing of the toes. So we just don't see that. I mean, we would have to see it in women exclusively. And, you know, I do get women coming in and saying, I can't believe this. I've used good shoes my whole life, and look, I've got this high heel shoe condition. You know, how has this happened to me? So I would say very, very small amount. Very, very small amount. Yeah. It sort of looks like it though, doesn't it? Because you think, well, if you look at the point of the shoe, is that really causing it? So there's not a lot of evidence for that at all. But I would certainly say don't use them because it does cause other stresses in the feet. But actually causing that sort of deformity, probably not. And in fact, that first claw toe I show you was a man. So, yeah. So these next set of slides are much, much more risk. So we're talking about an upper elevated level of risk now. And you can actually see how it looks worse, can't you? I mean, this is looking worse. So this is a peripheral vascular disease. And you can see this black patch here, up and through here. So this is sort of like the chilblain, isn't it? Looks a little bit the same. But this person here, those areas are gangrene. So this tissue is dying, and this person is needing some vascular care for sure. And in a case like that, potentially those toes would need to be removed. So this is now peripheral vascular disease. This is now the circulation has gone from, my circulation's not quite so good and my feet get cold. This is now becoming much more risky. And this was another part of the work I did, was monitoring people with peripheral vascular disease to make sure that their skin was staying safe and that their vascular system was still coping. And you'll be able to see this. You know, a person might say, I've got that chilblain again, or show you. This would be a lot more painful than a chilblain. So if they say, oh, that chilblain's got serious, it's really, really sore, you'll be thinking, you know, we may look at something a lot more serious. And this person needs to be immediately seeing a doctor. And I think that's one of the best advice you can be giving people. If you know something's becoming seriously painful, it's always a bad risk. If this was to get infected, you may not see it. So the effect of the infection on the body, that immune system rising to the challenge of that, this foot probably couldn't do it. So it won't get red particularly, because the immune system down in the foot in the circulation can't mount an effective fight against this infection. So you may not see the cardinal signs of the infection. It may not get red, there may not be inflammation. These come very quiet. And the last one of these I saw when I pushed around the toe, it almost felt like this awful, I don't know, it's hard to describe, pushing on something that's like crackling paper, and there's just like a rotting kiwi fruit underneath. That's what it felt like. And just straight away you know that all the skin under there, even though the surface just looked a bit red with a black spot, underneath it had all gone. So that person had to have, in fact, their foot removed below the knee. So this is why it's so important to get on top of these really quickly, because that person could have had some vascular surgery to encourage the circulation. So something to really think. And this will often be a person who's had chilblains and say, every year I get bad chilblains, you know. But this is the one that, you know, when you see that, you'll see that, wouldn't you? If someone said, oh, look, my foot's really, really sore, and you can describe it and say to them, you know, are you sure it's not going black? Are you sure that it's not, you know, anything more than your normal chilblains? So that's in quite bad state. This is an ulcer. And the amount of these that I find, because when I'm looking at somebody's foot and then I look and say, what's that just up under your trouser leg there? Oh goodness, that's an ulcer. How long's that been there? Oh, that's healing, I think. And I says, well, it looks pretty hideous. It doesn't look like it's healing. People will just ignore these like it's nothing, because they don't walk on it. They can sort of almost unload it a wee bit. But that one there is a vascular. So that wasn't from a wound. The skin just collapsed because the circulation was so poor. The skin just could not continue to survive there. And that is serious. That's a serious problem. Why? Because the vascularity can, you know, obviously continue to allow that to erode down. That'll erode down to the bone, left like that. It will then get infections in it, and then that creates a wider and a much more acute risk, of course, to survival. These sort of things, when they're starting to be treated, can take months and months to settle down, literally months, if they settle at all. And again, if it doesn't settle, what happens? Unfortunately, that limb has to be removed. So if you see these, hopefully if you see one, hopefully you won't see one. If you see one, hopefully it's small. And then you can say, no, you do need to have that look. You can't just have a wound appear on your leg and ignore it. These also can be wounds. So this person, before this occurred, may have been out in the garden and damaged their ankle. And then they've got a wound which won't heal because the circulation isn't good enough. So, you know, any wounds like that, absolutely get seen. Again, would we expect to see the infection signs there? No. The circulation, the immune system probably couldn't mount a particularly good sort of response to that. So you won't see the infection signs quite so easily. It probably won't even feel hot at all.
Sort of masks the healing, doesn't it?
It does.
Lack of healing.
Yeah.
You think, as they said, oh, and you think that's healing, but it's the reverse.
It's absolutely the reverse, because they will look and say it's not painful, it's not sensitive, and that's it. And sometimes, you know, their vascularity that bad, of course, their nerves are probably almost completely shot anyway, and they're sort of coasting on the fact that they've got all these injuries and bits and pieces in their feet, and they just ignore it, because yes, there's a hole in my leg, but I can't feel it. And I would say to people, there shouldn't be a hole in you. You know, we're not designed to have holes in us. And in fact, I had a patient, I was shocked. So this person had come in. I saw a small amount of leaking from the top of the foot. And the person says, I can't remember exactly what this lady said. I can't remember how she worded it. It was like, oh, whatever. And I says, no, there's water coming out of your foot. And she was like, oh. And I said, no, there's water coming out of your foot. She went within, and I was shocked at how quick. So I said, you need to go to the hospital now. She went to vascular. She was in vascular within a day after seeing her GP who concurred with me. Within a week and a half, she had a wound this big on her foot, down to the bone. They couldn't stabilise it. It went from just a little hole in her skin with nothing visible, suddenly that's what it was. And her foot was like this to start with. So edematous, foot was very swollen, and then she just had a little wee wound where water was coming out. And that's how quickly it went from just being a little bit of leaking, it's a bit of leaking, to a point where that wound was so deep, it just couldn't be stabilised. I was shocked at how quickly it moved, down to the tendons and the bone. So again, if you see a foot, you know, really swollen like that, that needs a comment. So there's fluid manifesting in the foot, that's stopping circulation, pressing on nerves, everything's going wrong there. And the GP needs to look at that. They might just need some water tablets, you know, that may be congestive heart failure. This is a symptom of something. So if you see these really puffy feet, you know, just say, hey, have you had that looked at? And again, people will sometimes slowly have their feet get bigger, and they'll just not notice that it's bigger, because it's been getting bigger for a long time. So I think that's something certainly to look at.
So what's that condition called?
That's just edema, yeah. And edema is just this fluid building up in the foot and leg, but it could be for many, many different reasons. Some of them more sinister than others. We'll come to that last if we get a chance to. Now, if we think about injuries in your group, so sometimes it's not the corns and the nail injuries and that sort of thing that are stopping them and causing them pain. And sometimes it's not serious vascular peripheral neuropathy, that sort of thing. Sometimes they've just gone and injured themselves. And so this is an Achilles tendinopathy. So if you look at the Achilles here, nice easy lines to see. You can see all the swelling in the back of the ankle there. And that's just an Achilles tendinopathy. And over the age of 70, I see a lot of people with Achilles tendinopathies. And they've tried to do the right thing by starting to increase their activity. What do? Too much, wrong shoes. And then they get an injury, and of course it confirms, well, all that rubbish about getting more activities done me no good. It's clearly dangerous out there. So this will need some help. So if you can see that they're really having some pain with that, get them to a clinician, physio, GP, podiatry, osteopath. They need to get that settled down, because these become so gluggy. I've seen people that have had them for 3 or 4 years before they've decided to do anything about it. And so that's what it looks like. That will tend to be quite hot, and it will be damnably sore, but it can be resolved. The main thing with these is if you're sort of advising someone a little bit about keeping them more comfortable, make sure they're in shoe with a bit of heel height in it. A lot of shoes now have no heel height, dead flat. Make sure they go into something like about that much, you know, just a normal shoe, even like this trainer, this one here. Some of the normal shoes that people are using now are just too flat, and that will put more stress. So you need a little bit of heel height will actually really help with that. But by the same token, they do need to get some strength work and some assistance with that. And that'll stop them walking. You know, that could be one barrier. You could get to your client and say, let's go for that walk, and they'll just say, I can't. Well, too painful. The next big one in your cohort of clients is plantar fascia injuries. Now, you probably had this yourself. Most people have probably had this, that heel pain thing. So plantar fascia is a band that runs from the big toe and it runs all the way back to the centre of the heel. And it can be injured anywhere from the big toe to the heel. Most people tend to have that pain in the heel though. And this person has ruptured it, so it's bleeding inside as well. So with this again, it will stop them walking for sure. Again, the Band-Aid response to this is make sure they're in supportive shoes, that they're in shoes with a bit more heel height, and putting some warmth on it, like a wheat pack, that sort of thing can keep it warm, but they need to get it seen clinically. So this is an injury and it does need to be looked at. Sometimes it's just much more this kind of tedious pain in the heel and not the severe. If it's just that pain is just starting to get a bit sore in the heel, cushioning in the heel. You can just get nice simple cushions, soft cushions from the pharmacy that can actually start to get it back under control. And shoes, cushion shoes. Again, rigid, hard leather shoes, you know, there's no softness in them. So something with some cushioning, like a trainer. And that can make a big difference to these, and it just makes it more comfortable. Not serious, but certainly can stop them getting out and enjoying life.
Do they heal by themselves?
They absolutely do, yeah. They don't always, and that's the problem. I would always say to patients, give it, say, 4 or 5 weeks. If it's not settling in 4 or 5 weeks, we need to do a few more things. But in general terms, plantar fascia does have its own life cycle. So, you know, I speak to a lot of people that say they've had it, oh, it just was there for 3 or 4 months and it went away. So they do tend to settle if they're quite moderate. But if a person notices they're ramping up and getting worse, or if they've just had it for more than about 5 or 6 weeks, they should get some advice on it. But plantar fascia is one that does tend to settle relatively well on itself if it's moderate. But as long as the person's playing fair with it, you know, go into shoes with a bit more support, a little bit of heel height, they tend to play fairly fair. The knee itself can have a lot of issues. I won't go into lots of them because it's a very complicated area. But it can be because of arthritis in the joint itself, because it's going to be one of the most common things. There's people just with arthritic knees. And it's pretty hard to get round that, except we still recommend movement. We still recommend people keep walking to comfort. And strength, it's that strengthening stuff, which your probably team is doing as well, doing strengthening work for the quads and that sort of thing. Absolutely. Yeah. So when we have strong muscles around a joint, those muscles take the energy out of the joints. So think about muscles as being an exoskeleton. This is not very strong. So cartilage on a joint, if I took cartilage of a joint and scratched it with my finger, it's destroyed it. It's that delicate, believe it or not. Bone is actually a very fragile structure. You can break it, just snap it in half. It's not that strong. It makes everyone feel a bit fragile, doesn't it? What makes us strong? It's the muscles. So if the muscles around this knee are strong, then the energy of walking goes into the muscles, and the muscles deal with that. So strength, strength, strength. It's interesting the amount of times I'll see a person 85, 95 coming in and I'm giving them exercises and they look at me like, no, you've got the wrong person here. I'm 85. And I'm saying, yes, that's why you're getting these exercises, because you need to be stronger. Sit stands from a chair, starting to get these muscles working. Little wee heel lifts, just nice and simple. Holding a wall, doing heel lifts. So I always tend to think about this area is best being treated with strength. Keep the joints working. So any questions there?
When I join one of these classes, easy as you go.
Yep.
It's when you do the standing and sitting,
Yep.
my knee twinges, but I don't let it stop me.
Yes, yep.
Yeah, what do you do about it?
What do you do? Yes, and it's an interesting perspective. When we do sit stands, it's a phenomenally good task. It's a very important task. I would say it's a life-changing task for most people if they can't do it easily, because what we're doing is we're using what I call anti-gravity muscles. What's the great challenge of mankind? It's not what everyone thinks, it's gravity. That's what we've struggled against for 100,000 years, is gravity. So all of the muscles that we use to bring us up against gravity. So when we sit stand, those are the muscles we should be working. However, if you sit and stand from a chair, if you just use your quads, you're putting all the stress on your knees. So what should you be using? Buttocks. So what you can think if your clients are getting sore in the knees, is make sure they're thinking push up from the chair, not pull up with the knees. So if you all do that, if you stand from a chair, think about how you do that. So if you stand up now, everyone stand, does it feel like the hips are pushing you up, or do you think you're pulling up from the knees? Pulling from the knees. So you can think about that. So sitting and standing should be just straight up out of the chair. Pull your feet back to a position that when you stand, you don't have to sort of pull yourself forward. And you should think, push from the hips. And then the big hip muscles are working. That's the goal of this task, is not to wholly use the knees. It's a powerful push from the buttock. And so bang for buck, the two exercises that I love in any age group is heel lifts, holding a wall or the back of a sofa, just doing heel lifts, just starting that process, and sit stands. And sit stands can also be seen as balance, because when we're getting up, we need people to be able to get up out of a chair and not start toppling. So that process of getting up with power, and I tell people when they come up, stand up, you know, not sort of just get up out of a chair and do this. To stand up, lengthen, use all those anti-gravity muscles, get yourself into that tall position and hold it, and then try to use that. And then the knee does less work. So
You're so good at the bus stop too.
that's right. Always snack on exercises. There's so many exercises you can do, you know, just waiting in a supermarket or something like that. Now, if we go through a little bit on the theory of walking, so I think this can be useful. So if we look at this person here, this is a young person taking a step. So the first phase of walking is our heel strike. And in a younger group, that will be relatively long. Now, as people get older, that distance of that step length will get shorter. This will shorten because it's precarious up there, isn't it? When you're doing this, it's precarious. It takes more energy. And there's more stress on the foot, etc. So in your clients, you might notice that they're walking with quite short steps. And the question would be, should we encourage them to take bigger steps? Well, energetically speaking, it can make a difference, yes, but you've got to be careful about their balance. So you've always got to be quite careful when you help direct. If you want to sort of think maybe longer steps, it can make a difference, but that may be something they could try at home when they've got the wall to protect them. I love walkers. I love walkers for people walking as well, because they can take those nice long steps again because they're protected. They've got that balance assured. So I've got a lot of people doing their exercise programs with walkers simply because I know they can take bigger steps and use muscles more efficiently. But in general terms, as we age, we'll tend to see a shorter step. The other thing that will change is the width of the step. So when I take a step, my feet would basically be about that far apart. That would be normal. As I get older, I know that my feet will start to get wider. Why? Better base of gait, yeah, more balance. And so the real challenge again is still against gravity, and we've still got to feel secure. So like I said, when you're looking at your clients, you will tend to see a shorter step through there. The upper body also will tend to be slightly more flexed. So we will often see people starting to walk much more this. This is something I think is nice to talk to them about, is try to get them up a little bit taller and not try to get them there the whole day, you know, whipping them along with a stick and say up again, you know, but just starting to get them thinking about lengthening up a wee bit, because if we're walking with ourselves in a more vertical position, muscles are working better, particularly our core. Once we get into this position, muscles aren't working so efficiently. So as this person goes through, weight is coming on to the front leg and the other leg is swinging through. Now you can actually see how stiff the knee is on that standing leg. It's quite stiff, isn't it? It's quite extended. As we get older, that will tend to get more flexed. So you will tend to see your clients, again, taking a shorter step and just probably flexing more at the knees and having a little bit more knee bend. And that in itself can cause trouble, but it's part of that strength thing. So sit stands. If we start doing those sit stands and getting the muscles stronger, they can start working up against that. You can see one of the complicated parts of walking. Look at the foot swinging through. Ridiculous, isn't it? Look how close to the ground that is. And we clear the ground by about 4 millimetres. 4 millimetres. And that's a risk, that's a hazard. Nature should have worked out that that's a hazard. Should have been highlighted many hundreds of thousands of years ago. But that's why people tend to trip. So, you know, how many times have you tripped on something and looked back and expected to see a brick about this high on the road, and all you could see was this? Our foot naturally clears the ground by a very, very small margin, and that's about energy efficiency. So as we get older, that tends to lift up a wee bit, and you'll see people starting to walk with their heels and their feet swinging through higher. I don't tend to stop people doing that simply because the risk of tripping, and it is a safer option. And particularly if people have had something like a stroke and they may have a bit of foot drop still, they will have to walk and lift that foot higher. One of the really important things that you can help with though, if you look at this part of the cycle here, see how the heel on the back leg is beginning to lift? So the heel on the retreating leg, or the leg at the back, lifts long before the other foot hits the ground, and that also tends to change because, again, this is precarious, isn't it? If I'm losing my balance and I don't have such good strength and then I'm in the air like this, oh, hang on, it's more precarious for sure. But it's very healthy for the muscles to do that. If every step I take, I'm lifting my heel, I'm using my calf pump, and that is the second heart of the body. So what's important about that? Well, blood comes out of our heart, high pressure, hits the floor, and it's got to do a complete turn and come back up again with no heart pumping it. That's where it becomes stagnant. If you activate the calf, the pressure on the veins will help push that blood back up. So when we end up with people walking with that nice little bit of heel lift, we're getting that vascular return system completing. We end up with a condition called dependent edema, which is when people are walking completely flat foot like this, and they're just not using their calf muscles. So when I see that, I always want that person to start doing some heel lifts, to start getting that strength built up, completing that circulatory response. It may not have them walking naturally with their heels lifting securely like that, because again, that does take a little bit of balance. But I see a lot of people that have stopped doing that, and there's nothing pathologically wrong with their balance, they've just got a bit lazy. So something to think about. So any questions with that? With the walking side of it? Any questions you've got with your clients and their walking?
Probably just wondering the impact that vision impairment has on how gait changes.
It will go into a protected mode, and it depends of course on their vision loss. Sometimes people will tend to look much more closely at the ground in front of them because their peripheral vision. So I can quite happily walk looking there. I can see there's nothing here. I don't focus on it, but I know there's nothing there. They may be looking very much at the ground, which drops their head forward, and then they're walking like this. They will tend to walk a lot shorter as well. So they're going to have short steps because they want to have that ability to haul up quickly if they've missed something. Also vision. When we talk about balance, or that kind of ability to be balanced and moving, its inner ear is the biggest part of it. So try to do walking without an inner ear, doesn't work. Inner ear, our strength and control of our central mass, but the third thing is the vision, isn't it? And so a big part of balance is that ability to see a horizon. And if you want to do that, how many people find it a little bit more difficult to walk securely when it's completely, really dark? Yeah, it just takes away that little bit of that extra. So when we think about that part of it, they will feel more unbalanced for sure. Yeah.
Sorry, also if you've got poor vision in one eye and not the other, you've got a change in your perception of depth.
Yes.
So
yep.
You have to look where you're walking.
Yeah, yeah. And there's so many different vision issues. There's so many vision things that can cause a problem. Also inner ear, vestibular stuff. There's a lot going on. What I would say is if balance is a big issue, if a person's having issues with vision, which they may have a stick anyway, but other balance things, even if it's normal degradation of balance over a whole lifetime, stick. How many people don't want to use a stick? A stick can make a difference. It's a third point of contact. It's another touch on the ground. Walking poles can be nice as well. Walking poles are really good. but you've got to be able to organise them. Now, I've seen some people with poles and, oh my goodness, trip hazard in each hand. So some people, honestly, if they want to think about that they do need to be well handled. It's, you know, people, and it's over here somewhere, and, you know, so you've got to know that they cannot tangle themselves in them. They can actually cause some risks to some people. But poles can be nice. It's 2 points of contact, or a stick. Yeah. And you need to attend to that, because that's the risk hazard, isn't it? The hazard is falling, and that's because of balance or vision or tripping on something. And that's why they will tend to get into these shorter steps. They will be slightly more flexed. That could also be trying to look at the ground, and so they'll tend to move along like that. And clinically, I do a lot of work with people trying to move them out of that, you know, getting them up taller, taking longer steps using heel lift. But that has to be clinically measured and monitored, so you actually can see where the risks are occurring. Sometimes I'll say to people, no, that's not going to work for you. It's too precarious. But the thing I think is nice to do, except where vision is a problem, is getting people thinking up taller. And the only other time I would say that's not good is sometimes I'll get people coming up taller and then they'll sort of go like this. And some people just can't get there. And the reason is their vestibular system, if you put them near vertical, and I hate the concept of people falling backwards. There's no redemption going backwards, is there? Going forward, okay, we're probably going to break a wrist, but we're not going to hit our head. You can do something, you go back, there is no redemption. So whenever I see anybody a bit precarious that way, and in fact, a gentleman 4 or 5 years ago, he just walking, when I saw him, he's just walking, it's like, oh my goodness, we're going to have to do something about that. So all I did was put a little bit of heel height into his shoe to just try and nudge him forward a wee bit. So yeah, you want to think about that as well.
Are you going to cover walking with blind people?
No, not specifically. Have you got a question specific?
I've got a new person here, and he holds me at the elbow.
Yep.
But he could do with standing up more.
Yeah.
Other than that, I haven't really observed yet, but I was thinking, well, how could I help him walk better?
It's more a tactileness. It takes time to get that person used to your movements and used to what he wants. And it's best to ask him what he prefers, because it's all to do with your body movement and discussion. It's a constant. There's something coming up. Keep him engaged. So the best way to relax him will to be talking to him. What's coming up? Oh, we've got a rubbish bin coming up soon. You know, he then knows that you haven't just going, oh, you know, that you're still engaged in the activity, that you're monitoring things. He wants to know what's happening, because think about it, you're going to say, I'm not going to run you into the bin, but he's still not sure. He's sort of thinking, what's out there, what's out? So just talking him through it, but also getting your body movement so you can actually know how he prefers you to move him. And I have a patient many years ago, and it's quite extraordinary, because it's not like I was walking him a lot, but he would just come careering into the room like this, and I'm having to pull him back again. He was just all over the place. And so it's just getting that calm movement where your body movement can help direct him, and then he can settle into that. So that's probably the best way to think about that. But it is hard. You need time together to get that right. But it's about that contact and discussion. Just keep him engaged with what you're doing, and where you're heading and what's out there. Yeah. Good. Thank you.
Thank you very much. That was absolutely fantastic. Thank you for sharing your experience and your knowledge with us and your expertise. Really appreciate it. Such an important subject. And I think we've all learned a lot today. So a round of applause for John.